Network for Mental Health. I have a disclaimer right off the bat. I'm not Kevin Hennessy, as you see in, from SAMHSA, as you see in your guide. I'm actually Nicholas Waters. I'm the Director of Knowledge Exchange Centre at the Mental Health Commission of Canada. Unless if you really don't like this presentation, then I am Kevin Hennessy. I'm from SAMHSA, and it's in there as well. And so Kevin actually just couldn't make it today, so I'm filling in for him for today's presentation. Our presentation will cover off a couple things today. We'll talk about the network and how it was formatted. We will also talk about a specific program, the Spark Training Institute, which we created in Canada and then was replicated in New Zealand, in Tapo. I'd like to start with this issue of what we have in our system. So,
You're Swedish, fantastic.
What happened?
I
was translating.
Interesting.
What just happened?
You can please translation.
This is an
Where am I? Where am I? I'll help you.
Okay.
Where am I?
So that. Where am I?
You are 30 meters up in the air in a balloon. You have to be researcher. Yeah, how did you know that? Because it's everything what you said is absolutely correct, but not useful at all. You have to be a politician. Yeah, how do you know that? Because you don't know where you are, where you're going, and you blame me for not knowing it.
Thanks for the collaboration.
Sorry for that.
That's okay, that's fine.
Let's have the rest in English.
Yes, the rest will be in English, unless we're translating some of the slides. So I just want to talk a little bit about the formation of the network. And so this was jointly envisioned by the Mental Health Commission of Canada and the International Initiative on Mental Health Leadership. And we have the CEO of the IIMHL in the room. He's holding the camera. I think he's videotaping me right now. Fran, if you could just raise your hand. If you have any questions about the International Initiative for Mental Health Leadership, he will be happy to answer that. We looked at why we were creating that, and it's really to connect people, ideas, and resources on a global level. When we were starting to form this network, we wanted a steering committee from across the world, but also organizations that would have buy-in. So organizations that would actually support knowledge exchange or knowledge translation or knowledge transfer, however we're calling it, implementation science. So we needed a good set of people on that. So I'll talk about the composition of the steering committee in a minute, but Fran, again, he has connections across the world, and so he spoke with many organizations, and then we found 9 representative countries who would sit on the network. We held 2 in-person meetings. The purpose of this was really twofold. We had the first meeting in St. John's, Newfoundland, Canada last year. This was really to set out what we would be doing as a network. The last thing we wanted to do, there's hundreds of networks in health across the world, but are they actually solving a specific issue? Are they looking at a specific problem? Are we trying to solve something that isn't a problem? Do we actually need a network? So that first meeting was a 2-day meeting to really set out some of the activities that we'd be working on. The second meeting was in Auckland, New Zealand, this past March in collaboration with the IIMHL meeting. This was where we really sat down, and after thinking about the activities we wanted to cover, mapping out a draft work plan for the next 2 years. So the structure. 9 countries are represented on the steering committee. We have Australia, Canada, Ireland, United Kingdom, Scotland, Sweden, and the US. We also have an implementation working group. This implementation working group was actually the group that put this presentation together. We meet about once every month and a half to 2 months. It depends on summer and everything. But we talk about a couple things in specifically. We talk about best and promising practices. This is both in research, practice, and policy. We talk about failures. I think we're always a little bit afraid to talk about what didn't work and why it didn't work. So we do really focus on those issues. And we talk about some innovative tools and tactics as well. So our meetings usually have one of the countries speaking about a particular topic. We then have a discussion about, what went wrong, what went right, how we can transfer that, what are some of the challenges, what are the barriers. And we have a fantastic discussion around one specific issue per meeting. We also have about 70 members from 9 different countries, and this is a research policy and practice network. And so I heard some of the comments in the last session about getting research policymakers and practice around the same table, speaking about in the same language, trying to counteract some of the issues we had in our cartoon about not understanding the context of the situation. So we have three, coming out of that main first meeting in St. John's, we had three main kind of focuses to our work. One, to enhance our collective ability to facilitate application of evidence-informed knowledge. And I just want to say, when I talk about evidence-informed knowledge, it is a bit different. We're talking about pragmatic knowledge, scientific knowledge, cultural knowledge, and learned knowledge. We're not just focusing on scientific. So we are looking at the full spectrum of knowledge when we're speaking about knowledge, as in this network in particular. To understand and share and apply strategies for skills in KT in the field of mental health. And we also look to be leaders and learners. So the one thing that we don't want to do is just tell people how we should be doing it, and that's it. We really want to learn from other networks. There's been lots of networks that have made great strides, but there's also been lots that have made mistakes, and we want to figure out how we can learn from them. We also want to add to the literature in KT. So we do a little bit of different things when we want to be learners and leaders. So our focus and activities. So we have three really kind of streams to our work. One is building capacity. The other is sharing knowledge and resources, and the third is increasing the uptake for evidence-informed practices. So if you look at the capacity building section, that's really our Spark Training Institute. So I'll speak about that a little bit more on the next slide. The sharing knowledge and resources we do through webinars, which will be starting in the fall of this year, hopefully October. So those will be international webinars. We also will have an online community of practice where we'll share all of our resources, which will be on the Mental Health Commission of Canada's website. Should be about October as well. When we're talking about the third, the increased uptake for evidence-informed practices, we're speaking about the increase of international submissions to SAMHSA's NREP. And so I won't go into detail about that. If Kevin were here today, he would go into detail about that. But if we have a discussion on that, I'm sure I can bring back some questions for him. So what is SPARK? SPARK stands for Supporting the Promotion of Activated Research and Knowledge. It is based on this guide that I have in my hands right here. This is the Innovation to Implementation Handbook. This is available on the Mental Health Commission of Canada's website. It's really just a step-by-step guide on how to conduct knowledge translation in Canada. There's 7 steps, there's questions that you follow, and there's also some tools and techniques. It's only about 25 pages, and most of that, there's about 12 and a half pages to actually write in this book right here. Let me give you a little bit of an overview of Spark. Back to the evaluation. There you go. So Spark, it's an application-based institute. So we had about 120 applications for the first Spark training in Canada. It was held in 2012. Each person who's applying has to come with an idea, a problem, an issue, a policy, or a program that they would like to be able to build a KT plan for. They also had to have organizational support. If they didn't have organizational support, then they would be graded higher when it comes to the adjudication process. So when we had those 120 or so applications, we adjudicated them down to 40. The first 2 days, there was a workshop where we actually went through this guide, and we basically walked through their plans and then built them a KT plan. At that point, it was a draft plan, and so coming into the following 9 months, it's a mentor-based institute. So we paired about 6 people to 1 mentor who were leaders in knowledge translation in Canada, and then they walked through the process and helped them create a full plan, also helped them implement the plan in their jurisdiction, also helped them evaluate the plan, and then we had some learning events along the way. This was 100% evaluated, so we did a pre- and post-workshop acquisition test. Our first Spark, which was held last summer, its final report is coming out soon, and we can actually show a gain in knowledge of a certain percentage from before they came to the Institute to after. So it is shown to be effective, and our actual full evaluation will be on our website probably in mid-September, and then I can share that with anyone who wants it as well. So I want to talk a little bit about Spark in New Zealand, and so now I'm playing a different hat. I'm not Nicholas, I'm not Kevin, I'm Jane, who's in the front row here.
Doesn't look anything like me.
Yeah. So Jane, we didn't want to have 3 speakers, so I'm going to fill in this part, and then during the question and answer, if there's any questions you have specifically for Jane, just please address them to Jane. So Spark New Zealand was the same concept, but slightly different target audience, and so it was really aimed at health professionals in the academic context, district health boards, the NGO sector, decision makers, family service advisors, and those working in the disability sector. So the goals didn't change, the overall kind of vision didn't change, but some of the target audiences did. Very fancy graphics too. So we want to just talk about the linkage. So how did this happen? Well, essentially it happened through the IKEN-MH network. Jane and I and another colleague of mine were on a teleconference call, and we raised the idea of Spark. Jane then said, sounds like a really interesting opportunity. And our first IKEN-MH meeting was in July, and then 2 days later, Spark happened. So Jane asked, can I attend Spark? Can I add an application in? So she decided to come. She had an application for a program that she wanted to build a KT plan for, but she really wanted to see the context. So what was Spark like? What was it all about? How would this fit in New Zealand? And how could we grow the program? And so Jane did come. She liked it because we started moving forward on that, which I'll talk about. The context is a little bit different. So I want to provide a little bit of context for TOPO, and if I get anything wrong, you can of course jump in and add in. So TOPO is funded by the Ministry of Health to support implementation of their policies. There's 3 core components: workforce development, commissioned applied research and uptake of that research, and using outcome information to benefit the system. So through that, why was it appealing? Through Jane, we were brainstorming on why TOPO decided to allow this kind of program to be replicated in your jurisdiction. And one was to improve the effectiveness of practices. Also to look at practices that weren't working very well, and why weren't they working very well, so how can we improve these practices? One of the bigger pieces was increasing linkages between researchers and direct delivery of mental health services. And the other is really just to develop the field of KE or KT in New Zealand. People are doing it, but they're not doing it formally. They're not a knowledge broker. They're not a knowledge exchange specialist or a KT practitioner. They're people who are doing it off the side of their desks. So we wanted to ensure that we could grow the field within New Zealand, and this is one way to start that. So how did the process go? So we started the Mental Health Commission of Canada, the MHCC. We provided all the materials free of charge to New Zealand. The only thing that we asked is any contextual adaptations they did, they still recognized that the program was created in Canada. Everything else, we didn't care if you changed anything, as long as the logo was on there and the recognition of where it started. They started a National Leaders Advisory Group. And we sat on that group as well, but it was made up of people across New Zealand. But it was really looking at, is this going to work in New Zealand? What's the value to New Zealanders? A couple things did come up about the language. So KT and KE aren't prominent terms. So how do we change the language to make it more accessible? What was there competing programs? So were there programs in New Zealand that already existed that may be a better fit? And the other was really just, was TOPO the right organization to move forward with this type of program? Was it a university sector because it's training? Should they start with educators, with the education sector and move forward? These are some of the questions that came up in these teleconferences. They were held on a monthly basis. They looked through all of the program information that we had and then built that into changing the model for the next year, or for their context, excuse me. So some of the adaptations that they put into their workshop, which was held on March 1st and 2nd of this year, was an increased focus on Indigenous knowledge context, some adapted language, as I said, a simplified evaluation process, focus more on the delivery and senior clinicians, and focus on the disability sector. And also the funding model is a little bit different. The Canadian model, we funded 100% of the participants' activities, so travel and everything, where TOPO funded everything except travel and accommodations. That was actually a picture taken from the training in New Zealand, and myself and Heather Bullock, who's at the back of the room.
Supposed to be presenting across there, so.
She's in 2 places at once. I'm sure her boss doesn't mind. Because we have a little bit less time, because I want to make sure that Frederick has time to speak about the policy perspective. Some of the learnings, and this is something that we are going to be replicating in other countries as well. There's interest from Australia, Scotland, the United States, and some other countries. It takes time to build awareness and readiness within organizations for knowledge exchange. So this isn't something that's going to happen overnight. Jane shared with me that she had to be on the phone with people whose bosses who were applied because they still didn't understand the concepts. And so you really do have to spend the time and energy with people to understand what we were trying to achieve. Obviously, you're going to have to target different target groups for your organizations. Leaders are important because they can actually create change within your organization. So looking at who should apply and who should attend was quite important. And then the development and sustainability. So is this the right format? Is 9 months sustainable? Is it 6 months? Is it 3 months? Should it be just 2 days and that's it? Should there be webinars that are in between that then use as kind of an update or refresher course? So that's the piece on Spark. And then the other part of the network really focuses on is the policy context. So how can we ensure that the system is ready for some of these changes and also best practices for transferring policy across countries?